Dear participants and respected physicians, সবাইকে আজকের MRI abnormal part 1 সেশনে স্বাগত। আজকে MRI বেসিক্স এর উপরে আমাদের প্রথম সেশন ছিল MRI বেসিক্স এর উপরে, আজকে আমাদের সেকেন্ড সেশন। যথারীতি আয়োজনে বিডি ফিজিশিয়ানস এবং আমাদের আজকে বুক স্পন্সর হিসেবে আছেন হেলথ কেয়ার ফার্মাসিউটিক্যালস লিমিটেড। আমাদের আজকের স্পিকার যথারীতি Dr. Praveen Kumar Yadav, Senior Consultant Neurologist and Assistant Professor. He did his MD in Internal Medicine, DM in Neurology, MRCP from UK, MRCP from London, FEBN from UK, FRCP from Edinburgh, FRCP from London, and he is also Chairman, Aragyam Neuroclinic. এবং আমাদের সাথে আজকে সেকেন্ড টাইম জয়েন করেছেন আমাদের একজন অত্যন্ত ব্রিলিয়ান্ট রেডিওলজিস্ট আমাদের মাঝে, যার আজকে দ্বিতীয় দিনের মতো আগতম। যদিও ম্যাডামকে আমরা স্পিকার হিসাবে ঠিক মতো এখনো পাচ্ছি না, ম্যাডাম একদিন প্রেজেন্ট করে ম্যাডামকে আমরা আশা করি শীঘ্রই ম্যাডাম স্পিকার হিসেবে জয়েন করবেন। আমাদের আজকে চেয়ারপারসন ম্যাডাম ডক্টর ফাতেমা দোজা। She did MBBS from Mymensingh Medical College, then she did FCPS and MD in radiology imaging. She's associate professor, Department of Radiology and Imaging, National Institute of Cardiovascular Diseases, ঢাকা। আমি আজকের সেশনটি শুরু করার জন্য আমাদের আজকে চেয়ারপারসন ডক্টর ফাতেমা দোজা ম্যাডামকে আহ্বান জানাচ্ছি।
Dear physicians of BD Physician, Bangladesh Physician, as well as dear Dr. Praveen Kumar Yadav, my good listeners, welcome and very good evening. I welcome you all in today's session of MRI Abnormal Part 1. It is to be presented by Dr. Praveen Kumar Yadav, a very known and I would say that a very popular neurologist who tells about the neurology as well as about the imaging in a very palatable way, and he's very popular to the BD physicians. He has Dr. Ehsan already mentioned that he's a senior consultant and chairman of Aragyam Neuroclinic, and today we are going to see his presentation on MRI abnormal. Dr. Yadav, please start.
Thank you, Ehsan Khan, and thank you, madam, for the introduction. So today we'll be going into the MRI abnormal. So MRI abnormal, I will be speaking mainly on basal ganglia disorders, Parkinson diseases, and dementia, as well as on pituitary lesions and brain tumors. So you see, it's a huge topic, so covering the entire aspect will be difficult. So I'll be highlighting on the key features and the basic clinical points in the neuroradiology, as well as I'll be giving the clinical context as well as the history of the patient, so that it will be easier for the clinicians to correlate the history as well as the radiology, so which will be useful in our day-to-day clinical practice. So I'll share my screen. So are the slides visible?
Yes, sir. Yes, sir.
Okay, so first topic is on the basal ganglia. So I think during the normal MRI, I had just gone roughly through the anatomy of the basal ganglia. So just a brief recap of the previous thing. So this is the basal ganglia complex, and you can see this is the frontal horn of the lateral ventricle, and just beside this is the caudate nucleus. So this is the head of the caudate nucleus, which we can see in the axial section. So this is an axial section, and this is a coronal section. So in the axial section, you can see this is the caudate nucleus. Here again, the caudate nucleus is visible here, head of the caudate nucleus. And this is the entire basal ganglia complex, which has the medially you are having the globus pallidus, which has the globus pallidus interna and externa, which is not much required. So you can remember that G, that is globus pallidus, is medial, and P, that is putamen. Putamen is outside. So this is the putamen, and outside that you are having the external capsule, and both this complex, that is the globus pallidus and the putamen, is known as the lentiform nucleus. And the caudate along with the lentiform nucleus is called as the basal ganglia complex. And then you are having the thalamus as well here. This is the medial part is the thalamus. So all the structures constitutes the basal ganglia. And then laterally you can see the gray matter here. So this is called as the insular cortex. Insular cortex is very important because most of the intracerebral bleeds which involve the insular cortex, it causes a lot of autonomic symptoms. So there is autonomic dysregulation. So it's an autonomic center. So insular cortex is just outside the basal ganglia. So this is again the MRI anatomy here, and this is the axial view, and it is the T2 image. So you can see the T2 image because the CSF is bright, and then the white matter is gray, and the gray matter is white matter is dark, and the gray matter is white. So this is the T2 image, and this is the axial view. This jutting round structure is called as the caudate nucleus, and this is the globus pallidus, and this is the putamen. And you can see the dark structure here, L-shaped structure. This is the internal capsule, and this is the posterior limb of the internal capsule. So most of the hemiplegia which we see, dense hemiplegia, the lesion will be around the posterior limb of the internal capsule. This is the thalamus. So this is the rough anatomy of the basal ganglia. Now, this also I have mentioned before, the lesions in the MRI, most of the lesions in the MRI will be hypointense on T1 and hyperintense on T2. Now, there are few lesions which may be bright in T1. So these are the exceptions. So what are the lesions which are bright in T1? Most important is blood, that is the meth hemoglobin. The late subacute bleed, you can see that the meth hemoglobin becomes bright. Then early stages of calcification, fat. So any fatty substance will be bright in the T1. Melanin may be bright. And then if there is metal deposition, especially manganese deposition, it can cause T1 brightness, which is seen in CLD as well as chronic manganese poisoning. And also one important cause is diabetic patients. So we know that diabetic patients may have hyperglycemia. And there is some entity which is called as HONK, that is hyperglycemic non-ketotic coma. So these patients, there will be hyperglycemia, ketone bodies will be negative. So these patients can have sudden onset of movement disorder. So it is called as hemichorea hemibalismus. So they present with unilateral chorea and flinging movements of the limb. So you can see that in patients, suppose if the right side of the upper limb and the lower limb and the face is involved, then you can see in the left side of the brain, you can see there is hyperintense lesions involving the basal ganglia. So that is a classical hallmark of hyperosmotic basal ganglia injury. And the neurofibromatosis can again rarely cause basal ganglia hyperintensities. So basically basal ganglia hyperintensities you can divide as acute lesions and chronic lesions. So that will be depending on the history. So if it is an acute onset of symptom, then it is acute lesion. And if it's a chronic symptom, then it is likely to be chronic. So what are the acute disorders which can affect the basal ganglia? One is toxins. So any sort of toxin like cyanide, carbon monoxide toxin, methanol poisoning. Sometimes the ethanol is it is mixed with methanol, and this can cause severe basal ganglia injury and can even cause death. So that is methanol poisoning, disulfiram reactions. All this can cause basal ganglia injury. Metabolic is hypoglycemia, severe hypoglycemia or hyperglycemia. Both can affect the basal ganglia. Uremia, and very important is osmotic demyelination. So the osmotic dysmyelination syndromes, that is sudden correction of hyponatremia by giving a very 3% normal saline very quickly, can give rise to involvement of the basal ganglia. So this is called as extrapontine myelinolysis. So that is one important entity. Then hypoxic brain damage. We see patients who are having cardiac arrest, and then after that they are getting revived, and then they are having a lot of myoclonus, and then they are having a low GCS, poorly responsive pupils. So in this case, if you do the MRI, you can see that there is involvement of the basal ganglia. The importance is that basal ganglia is a very metabolically active structure. So if there is a hypoglycemic, hyperglycemic or hypoxic insult, the basal ganglia gets predominantly affected. Not only the basal ganglia, all the deep gray matter, including the thalamus, are quite metabolically active, which makes them more prone for such injuries. Now, other acute disorders are a DVT. So venous thrombosis involving the deep veins, and also strokes involving the artery of Percheron. So all this can give rise to involvement of the deep gray matter. Then infections like Japanese encephalitis is notorious to cause basal ganglia damage. Also dengue encephalitis can also affect the basal ganglia. So these are the common acute disorders which can affect the basal ganglia. Now coming to chronic lesions, manganese toxicity, then metabolic disorders like Wilson's, neurodegeneration with brain iron, Wernicke-Korsakoff syndromes. We know about Wernicke's encephalopathy that can again affect mitochondrial disorders, chronic liver disease. This can affect the basal ganglia. Infections like HIV, toxoplasmosis have quite predisposition to the basal ganglia areas. And one important infection that affects the basal ganglia is Creutzfeldt-Jakob disease, that is prion disease. And other degenerative disorders like Huntington's disease is important cause of involvement of the caudate nucleus especially. So there you will get the classical caudate atrophy, which I'll be showing the images later on. So these are the acute and the chronic lesions which affect the basal ganglia. So this is a summary of what I said. One second, So you can have lesions, acute lesions, which can involve the globus pallidus, that is cyanide and carbon monoxide, involving the caudate nucleus and the lentiform nucleus, hypoxic injury and all those things, osmotic demyelination. Involving the lentiform nucleus mainly is uremia, disulfiram and all those things. Thalamus is stroke, venous occlusions and hypoxic brain injury. Caudate nucleus, hemorrhage, hypoxia, and then putamen is mainly methanol. So they are, you are having all the nucleuses, caudate nucleus, the globus pallidus, the putamen and the thalamus. So different lesions are having different predisposition of involving this nucleus. So based on this, we can have a good differential diagnosis also. So this is just to summarize what are the areas which may be involved. It is not necessary to memorize this. However, for radiologists, it may be quite important. Now, chronic globus pallidus. So this was about acute. Now coming to chronic globus pallidus lesions. So one important entity which we can diagnose with the use of MRI is, it is called as NBIA. So this is called, in other words, neurodegeneration with brain iron accumulation. And the most important cause for this is the PCAN mutation, that is the pantothenate kinase mutation. So before this disorder was called as Hilleverden-Spatz disease. And because of its association of Hilleverden and Spatz with the Nazi war crimes, the name has been changed and now the new name is NBIA or PCAN. Similarly, we can remember that the name of Wegener's granulomatosis, which was called Wegener's granulomatosis, has been again changed due to the Nazi association, and we are having the new name for Wegener's granulomatosis. Similarly, the Hilleverden-Spatz, now we call it as NBIA. So this is a progressive neurodegenerative disorder with extrapyramidal, pyramidal dystonia and dysarthria. And there is iron accumulation in the globus pallidus and the brainstem nuclei. And 50% of the NBIA is due to PANG2 mutation. That is the PCAN mutation, which I have mentioned. Now, we have to know that NBIA is a spectrum disorder. So you are having many types of NBIA, and depending upon the involvement in the nucleus, we can diagnose the condition by which is the exact cause for the MRI finding. So you are having the classical PCAN. You are having the infantile neuroaxonal degeneration, which is called as Plateau G6 mutation. You are having the atypical neuroaxonal degeneration, and the later onset disorders are neuroferritinopathy and aceruloplasminemia. So all this are the spectrum of NBIA. So depending on the findings, you can find out which NBIA is the patient having. And along with that, you may have to do the genetic studies as well. So this is the classical finding. So which we know is the eye of the tiger sign. So which is classical of NBIA. So that is seen with the PCAN mutation. That is the pantothenate kinase associated degeneration mutation. Now there may be, we have to know that the eye of the tiger is not required always to diagnose NBIA, because the other types of the NBIA will not have the eye of the tiger. So it is only seen in the PCAN mutation. So if there is no eye of the tiger appearance, and there is globus pallidus involvement, then you think of INAD, that is the infantile neuroaxonal dystrophy. If there is hypointensities involving the dentate nucleus and all those other structures, then you think of neuroferritinopathy. And the classical thing is cavitation will be here and confluent lesions will be seen in neuroferritinopathy. While in aceruloplasminemia, there will be no cavitation, but there will be widespread involvement of the CNS. So if there is widespread CNS involvement apart from the basal ganglia, you think of neuroferritinopathy and aceruloplasminemia. And if there is no cavitation, it is likely to be aceruloplasminemia. While if there is cavitation and confluent lesion, it is likely to be neuroferritinopathy. So based on the imaging findings, you can dissect through and try to find out which type of NBIA you are dealing with. A lot of other clinical features will also be there, like in neuroferritinopathy, you will be having a very high ferritin level, and aceruloplasminemia, you will be having diabetes and all those hypogonadism, etc., which may be clinical clues along with the MRI findings. Now, PCAN, this is the classical history. They will be presenting with distal visual blurring because of the eye involvement in the form of retinitis pigmentosa, etc. There may be pes cavus, optic atrophy, and spasticity and brisk reflexes in the lower limbs with extensor plantar. So they'll be having features of the extrapyramidal and the pyramidal involvement and eye involvement. So that is the classical history which we'll be having. And this is the classical sign of PCAN in the MRI. So you can see this is the normal basal ganglia. And you can see there is dark areas here in the axial images. So this is suggestive of iron accumulation. Now, here you can see that along with the iron accumulation, there is some hypergliosis or some hyper spot in the hypointense lesion. So this is the classical sign which is called as the eye of the tiger. You can see this is the dark spot, and here you are having the white spot here. So this is the eye of the tiger. If you see the eye of the tiger, then you can be fairly sure that it is likely to be a NBIA PCAN variant. However, you should remember that there are a lot of other differential diagnoses of the eye of the tiger appearance, which I'm not mentioning here. So it has a few other differential diagnoses also which can give rise to the eye of the tiger appearance. Now, there is another condition which is called as methylmalonic acidemia, which is an amino acid metabolism disorder. And here again, this will be occurring in the younger age group, and the child will present with vomiting, lethargy, dehydration, recurrent infections, and you will be having seizures, choreoathetosis, dystonia, dysphagia, and dysarthria. And so this is the classical finding of methylmalonic acidemia. It occurs in the younger age group with failure to thrive, seizures, strokes, and extrapyramidal involvement. So you can see there is hyperintensity involving the globus pallidus in the posterior part, bilaterally symmetrical. So this is one boy aged 12 years with developmental delay, cyclical vomiting, and this is a girl of 15 months, again having similar MRI finding. So if you get this MRI finding with a classical history, then you can suspect methylmalonic acidemia. You can do the urine metabolic screening or the tandem mass spectroscopy, which can help us in diagnosing these metabolic disorders. Now, this is the chronic deep gray matter nucleus. I'll not be going into the details. It will be available in the slides so that you can have a look later on. So various disorders can affect the various part of the basal ganglia. So globus pallidus is in the NBIA, the neurofibromatosis, methylmalonic acidemia will affect that. Lentiform nucleus in Wilson disease, toxoplasmosis, etc. Melas syndrome can affect the basal ganglia. Caudate and the putamen in the Leak's disease, which is again a sort of mitochondrial disorder. Creutzfeldt-Jakob, Huntington's. So this will be involving the caudate and the putamen. And thalamus in Wernicke-Korsakoff's psychosis, and Creutzfeldt-Jakob also the atypical Creutzfeldt-Jakob or the sporadic CJD will affect the thalamus, and you are having the classical signs which I'll be showing later on. And caudate is affected by the Huntington's disease. So the predilection to involvement of the deep gray nuclei is there. So this pattern, if you can recognize, which can help us in diagnosing the condition. So cyanide poisoning I've already mentioned. So usually on intake of attempted intake of the drugs, and usually present with encephalopathy and even death. And if the patient survives, then they usually have Parkinsonism and extrapyramidal symptoms. So you can see these patients, which is from the AGNR journal in 2002. So you can see bilateral symmetrical lesions involving the caudate and the globus pallidum and the putamen as well here. So this is a case of cyanide poisoning. Now, carbon monoxide poisoning, I've seen few patients of carbon monoxide poisoning, and then usually it is with gas geyser toxicity. Usually the gas leak occurs in a closed room, and then usually they inhale the carbon monoxide, and this causes severe basal ganglia damage. So here you can see there is involvement of the basal ganglia bilaterally symmetrically. So in the acute presentation, they present with comatose state and altered mentation, and then once they recover, they will have this Parkinsonism features. So they'll be having rigidity, stiffness, tremors, and all, which will be there, and you have to treat them with medications and all those things. So the long-term outcome, they have a lot of neurological deficits which persist for long. Now, hypoxic brain damage, as I was mentioning, it's a very common scenario in the ICUs, sudden cardiac arrest, and then the patient develops altered mentation, seizures, myoclonic jerks, and all those things. So this is the classical feature. You can see there is the bilateral symmetrical involvement of the caudate, the globus pallidum, putamen, and also the thalamus bilaterally. So these are the metabolically active sites. And once there is hypoxia, there is involvement of this site. Now, in the hypoxic brain injury, a particular sequence which is very useful is the diffusion weighted image. So if you have a HIE patient, you immediately, after 24 hours to 48 hours, you can ask for the diffusion weighted image. Now, diffusion weighted image, like in the first lecture, I had already mentioned that shows the cytotoxic edema. So if there is severe hypoxic brain damage, there will be cytotoxic edema involving the various parts of the brain. So that will be seen in the diffusion weighted image. So if there is cytotoxic edema, that means the prognosis is bad. And usually the patient will have long-term residual deficits if the patient survives. So diffusion weighted sequence may be helpful in the prognostication of the patients. Now, kernicterus, we again see a lot of patients, child presenting with severe jaundice, and then they develop this kernicterus, and then they're having long-term deficits. They'll be having severe chorioathetosis. So it's called as chorioathetoid cerebral palsy. So chorioathetoid cerebral palsy and dental problems and hearing loss. So this is the classical triad of kernicterus injury to the basal ganglia. And you can again see, so here you can see there is bilateral involvement of the basal ganglia in this patient. So this is bilirubin encephalopathy, otherwise it is called as. So this is again a disorder which has long-term deficits. Now, acute putaminal injury. So most important is intracerebral hemorrhage. You can see this is a CT scan which shows a right basal ganglia bleed, and MRI T2 weighted axial image again showing the same. So this is the diffusion weighted image. One thing I would like to mention is that here you can see that it's a very bright area here. So this is a diffusion restriction area. However, I do not have the ADC map for this. So here there is diffusion restriction. So diffusion restriction does not always mean infarction. So that is that in the last lecture I have mentioned, diffusion restriction can occur in many type of lesions. So it can occur in infarction, most important. It can occur in bleed if it's acute bleed. It can occur in abscess. It can occur in highly cellular tumors. It can occur in metabolic injuries to the brain. It can occur in herpes encephalitis. It can occur in CJD. So wherever you get cytotoxic edema or very high proteinaceous content or very high mitotic turnover, there you can have a diffusion restriction. So here you can see in the bleed, again, you are having a diffusion restriction here. And this is the gradient echo. And you can see there is black areas here. So that is suggestive of blood. So this sequence can be helpful in detecting blood, which I've already mentioned before. Now, methanol poisoning, it is again a common condition, especially the mixed contaminated ethanol with methanol. So methanol is used for the painting and in the painting of the furnitures, etc. And so sometimes it gets mixed with ethanol. So this can cause severe basal ganglia injury. You can see there is total swelling of the globus pallidus, putamen, as well as the caudate, and there is marked cerebral edema, and the MRI is again showing the same. And there is again injury involving the around the midbrain area, pontine areas in the posterior part. So this is classical of methanol poisoning, and it can be really fatal condition, and there can be visual loss along with that. So it affects the optic nerve, so and causes severe toxic optic neuropathy and can even give rise to blindness. So this is one condition which has to be looked on whenever a alcoholic patient comes with sudden onset of encephalopathy, headache, and visual loss in the emergency. So this is one condition which is again very common in the critical care ICUs. So this is osmotic demyelination syndrome. So now we may be thinking that osmotic demyelination means only in the pons. So that is not true. Osmotic demyelination can affect the pons, classically involving the central pons, and where we get the classical sign, which is called as the trident sign. So you get the central pontine involvement, while in an infarction, it will be either in the sides. So it will not be involving the central part. So that may be a very important mimic of osmotic central pontine myelinolysis, which is an infarction. So infarction will be paramedian, while this will be central, and you will get the trident sign. So it will be looking like a trident appearance. So that will be seen in the pons. So we all know about the central pontine myelinolysis, but myelolysis can affect the basal ganglia also. So it is called as extrapontine myelolysis. And you can see this patient again presenting with tremors, rigidity, and all those after treatment of the hyponatremia. And you can see there is bilateral involvement of the caudate nucleus and the basal ganglia, which is symmetrically involved. So if you see this picture in a patient who has been treated for hyponatremia and fairly rapid increase in the sodium levels, so then you can think of a extrapontine myelolysis. So what are the risk factors, or what is the group of the patient which you should be cautious about this condition? One is chronic alcoholic patients, and second is patients who are having multi-system involvement like CKD patients, CLD patient, patients with sepsis, and all those basic underlying conditions. So they are more prone for this osmotic demyelination. Sometimes even the sodium rise may not be very rapid. Even a very slow rise in the sodium can also give rise to this osmotic demyelination, especially in the patients who are in the high risk group. So you should closely observe the patients in the ICU who develop neurological deficits after treatment of the hyponatremia. Now, disulfiram poisoning, not very common. So, but again, that drug can give rise to bilateral basal ganglia injury. And this is one important finding which I would like to bring to everyone's notice. So you can see this patient who is a chronic liver disease patient and now presents with a lot of Parkinsonism features. So like tremors, rigidity, difficulty in walking, memory loss and all. And you can see that there is some flapping tremors, mild hepatic encephalopathy, mild subclinical hepatic encephalopathy. And if you do the MRI scan, so this is a T1 weighted image. This is an axial image. And T1 I say because the CSF is dark here and the white matter is white and the gray matter is gray. So this is T1 sequence. And you can see there is bright spot involving the basal ganglia bilaterally, symmetrically, and which is running into the midbrain as well. So this is due to manganese deposition. And this is a very important finding in chronic liver disease patients. So this is otherwise called as non-Wilsonian hepatolenticular degeneration. So if you see a patient with Parkinsonism features, not typical, and patient has liver disease, so this could be a non-Wilsonian hepatolenticular degeneration. So you can find these findings here. Now, neurofibromatosis can again involve the basal ganglia. You may have round lesions like this involving the basal ganglia complex. Not very common, but it can occur. And then metabolic disorders in the children, glutaric acidemia type 2 can again affect the basal ganglia. So methylmalonic acidemia, glutaric acidemia, MSUD, that is maple syrup urine disease, all the metabolic disorders can affect the basal ganglia, dentate nucleus, and the brainstem and all those structures, and the mitochondrial disorders as well. So you should look out for this disorder, and the differential diagnosis will depend upon the clinical profile, the age of the patient, and the history, as well as the neurological correlation. So you should have a clinico-radiological correlation whenever to come to a pinpoint diagnosis, because just the radiology or just the clinical picture will not give the findings. So you have to communicate with the radiologist, give the history properly and the investigation reports and the differential diagnosis based on your examination and the blood reports or whatever reports you have done to the radiologist, so that they can assess everything and then come to a diagnosis. Now, this is again one condition, common, middle-aged man present with involuntary movements of the limbs, 4 years, family history of psychiatric illness and similar illness in the family. So you can see what is the abnormality you note here. The most important is, you can see there is caudate nucleus. It should be ideally jutting into the lateral ventricles, but you can see the lateral ventricle is fairly enlarged. So there is caudate atrophy. So this is called as boxcar appearance of the caudate nucleus or the ventricles. So this is boxcar appearance, and you can see there is generalized cortical atrophy also. So this is suggestive of Huntington's disease. And the diagnosis is by looking into the genetic mutation, that is the trinucleotide CAG repeat mutations, which you can easily avail, as it is widely available now. Now coming to acute thalamic lesions. So one important lesion is toxoplasmosis. This is a 35-year-old male, HIV positive, not on ART. Now fever, headache, vomiting 3 days, altered behavior 2 days. Patient is drowsily, restless, and there is left-sided neurological deficit with extensor plantar, and neck stiffness is positive. CSF shows anti-toxoplasma antibodies, and you can see bilateral lesions involving the caudate, basal ganglia, and the thalamus with some asymmetry involving more on the right side. I could not get the contrast images, and there is other subcortical lesions also. So this patient has toxoplasmosis. Contrast enhancement will be there, and usually these toxoplasma lesions there may be some hemorrhagic involvement as well. So the closest differential diagnosis is a lymphoma in a HIV patient, and so toxoplasma is a important finding in HIV or immunosuppressed patient. Now this condition, it's uncommon. In fact, you can see there is bilateral thalamic hyperintensities, and this is due to the involvement of the artery of Percheron. So this patient, 35-year-old, sudden onset of unconsciousness, 1 day, no seizures, no risk factors, and then the patient is bit drowsy, no focal deficits, and the plantar is withdrawal. And you can see there is bilateral paramedial thalamic lesions with mild hemorrhagic transformation. So this is classical of artery of Percheron infarct, and where you can have bilateral symmetrical thalamic involvement. Now, this is a very important situation which should not be missed. This is a cerebral venous thrombosis involving the deep cerebral veins. So you can, again, in this condition, you will have bilateral thalamic involvement, though there will be a lot of edema and swelling along with that. And you should ideally do a MR venogram in this patient, because venogram will tell us about the thrombosis of the straight sinus or the deep venous system. And if you carefully look at this, this is a T1 sagittal view, and you can see there is a bright spot here, linear hyperintensity here. So this is the thrombus which is involving the straight sinus and the deep venous system. So this is a deep cerebral venous thrombosis giving rise to the bilateral thalamic lesion. So this patient will present with sudden loss of consciousness, altered mentation, and sometimes seizure, but seizure is less common in this situation. Unlike the lateral thrombosis, lateral vein involvement, or the superior sagittal sinus involvement, where you get the bilateral frontal lesion or the temporal lesion with a hemorrhagic infarct or a bleed, here usually there will be bilateral thalamic lesion. So always suspect a deep cerebral venous thrombosis, especially in patients who are having thrombophilia, or if the patient is on oral contraceptive pills, or there are risk factors for venous thrombosis. Now, Creutzfeldt-Jakob disease, you should be aware of this condition, which is also called as prion disease or slow virus infection. So whenever you are having multifocal involvement of the brain, so that means you are having cerebellar involvement, you are having extrapyramidal involvement, you are having cognitive involvement, along with seizures and myoclonic jerks, and which is rapidly progressive over a period of months, weeks to months, then you should suspect Creutzfeldt-Jakob disease. And the diagnosis is by doing the EEG, where you will get the periodic shortwave discharges, and the MRI, which is again very classical and very important. In this patients, MRI is the investigation of choice. So you can see here, this is the MRI scan of the patient, where you can see, this is my own patient. You can see bilateral involvement of the caudate nucleus and the basal ganglia bilaterally. And this is the diffusion weighted image, which I've already mentioned before. So here you can see there is hyperintensities involving both the caudate and the putamen here. So this is diffusion restriction. So diffusion sequence is the most earliest sequence which can pick the Creutzfeldt-Jakob disease, because there is cytotoxic edema. So this is the best sequence to do, and always have a look in this. And in the cortical areas, you can find out a sign which is called as cortical ribbon sign. So cortical ribbon sign with basal ganglia involvement is quite suggestive of Creutzfeldt-Jakob disease. Now, there are various variants of Creutzfeldt-Jakob disease. As I've already mentioned, the classical features which I mentioned, visual symptoms, ataxia, pyramidal symptoms, dementia, myoclonus, but sometimes this may be absent. So they may be presenting with psychiatric symptoms, they may be presenting with sensory symptoms, abnormal behavior, abnormal pain in the limbs, and all those things. So there you can think of a variant Creutzfeldt-Jakob disease. So in the variant Creutzfeldt-Jakob disease, this is the classical sign which is seen. There is hyperintensities involving the thalamic pulvinar area. So this is called as the pulvinar sign. And you see a sign sometimes called as the hockey stick sign also, which is again classical of variant Creutzfeldt-Jakob disease. So two other signs are pulvinar and hockey stick sign. So this I have already mentioned. Now coming to Fabry's disease, it's a very rare condition. Hardly I have seen 1 or 2 patients only. So this again presents with basal ganglia involvement. As you all know, this is again a multi-system disease presenting with peripheral neuropathy, painful peripheral neuropathy, skin lesions, eye involvement, renal involvement, etc. And here you can see there can be hyperintense involvements involving the basal ganglia. So this is one, again, differential diagnosis which you have to suspect if the patient has CNS involvement. Now, this is one common condition which I think every critical care physician or internist should know. So any patient, alcoholic patients coming with sudden onset of altered sensorium and having nystagmus and then ophthalmoparesis, eye involvement, you should always think of Wernicke's encephalopathy. So here you can see the classical finding is bilateral thalamic involvement, involvement of the fornix and the midbrain. So the midbrain involvement, thalamic involvement, fornix involvement, and the mammillary body involvement. Here you can see the mammillary body is hyperintense. So all those things are the classical finding of Wernicke's encephalopathy. So this patient has to be diagnosed early, because if it is diagnosed early, it is almost curable. But if it is diagnosed late, then this can give rise to significant neurological deficits, which can be long-term, which can be present long-term. So early diagnosis of this condition is required. Now coming to basal ganglia calcification, again a very common scenario. Now these are the various differential diagnoses of basal ganglia calcification. So commonly what I see basal ganglia calcification is, one is parathyroid gland abnormalities, hypoparathyroidism, hyperparathyroidism. Also in CKD patient, they will be having this parathyroid abnormalities which can give rise to basal ganglia calcification. Mitochondrial disorder is a common cause of basal ganglia calcification, and Far's disease, that is familial cerebrovascular ferrocalcinosis. So this is a common situation again for basal ganglia calcification. So all those things you have to rule out, and then toxoplasmosis, rubella, torch infections can cause basal ganglia involvement as well. So Far's disease, young onset, symptoms with Parkinsonism and involuntary movements and all those things. So you can see here, there is T1 hyperintensity involving the globus pallidus, thalamus, and you can see that T2 hypointense lesions are there. So this is basically due to the calcium deposition. Now you should always remember that we speak about MRI is the investigation of choice for brain disorder. But in two conditions, CT scan is better in diagnosing the condition. For most important is bleed. So intercerebral bleed, CT scan is the investigation of choice. And second is calcification. So calcification and bleed, CT scan is the best, because if you do the CT scan, it will be so easy to diagnose bleed and calcification. But however, if you do the MRI, then there are a lot of problems which happen, especially in the cases of bleed. So the bleed evolves into various stages, and then the MRI pattern also changes. So it becomes really difficult to find out. So the best is to do a CT scan. However, in the case of a chronic bleed, very old bleed, usually what happens is when you do the CT scan in the repeat sequences, the bleed totally resolves. And then you can see just a hypodense lesion in the CT scan. So this can be mistaken for an infarct also. And sometimes a lot of patients who do not do the imaging initially, or they have lost the previous scans and the reports, when you do the repeat scan, then the report may come as an infarct. And then you may be starting on an antiplatelet medication, and which can give rise to a bleed again. So in such cases, if you do the MRI scan, and if you do the gradient or the T2 star images, you can find the hemosiderin ring, which is persistent, which can be present throughout the life. So old bleed, very old bleed, MRI may be the investigation of choice. But for acute and subacute bleed, CT scan is the investigation of the choice. So I think we have completed basal ganglia disorder. I'll go into the Parkinsonian disorders. So one important condition is manganese-induced Parkinsonism. So I work in a city called as Durgapur. So it is a steel city. So what happens is that in the steel industry, they use a lot of welding and all those things. And then there are a lot of exposure to the manganese fumes, which give rise to this condition called as manganese encephalopathy or manganism. So in this condition, the patient usually presents with a atypical Parkinsonism feature. So they may be coming with rigidity, tremors, memory loss, urinary symptoms, and then a flexed posture. So it's called as a cock-up gait. So these patients, if you can do the MRI scan, you can find this finding. So you'll be finding that there will be T1 hyperintensity involving the basal ganglia. You can see this is a T1 image, coronal sequence, coronal cuts. and you can see there is hyperintensities involving the basal ganglia. So this is due to manganese exposure. So this is a very relevant clinical condition. So unless you remove the patient from the exposure of the manganese, the patient is not going to improve, and then there may be further deterioration, and it may even be fatal if there is a very chronic and high overdosage of the manganese. And you may need to give chelation therapy for these patients also to remove the manganese which is deposited in the basal ganglia. Now, other condition which can affect the basal ganglia is, this is a classical sign which is seen in multi-system atrophy, which is called as the putaminal slit sign. So you can see in the putamen there is a slit-like sign, and there is hyper intensity and then hypo intensity due to iron deposition here and gliosis. So this is called as a putaminal slit sign, which is a classical sign which is seen in multi-system atrophy P type, that is the Parkinsonism type of multi-system atrophy. Now this sign I think everybody will be knowing. This is called as the hot cross bun sign, so which is classical feature of MSA-C, that is the multi-system atrophy C type. So you can see it looks like a hot cross bun. This is due to the involvement of the crossing pontocerebellar fibers. So this is a classical sign. However, there are differential diagnoses for this sign also, like a variant Creutzfeldt-Jakob disease, a progressive multifocal encephalopathy. All this can present this like a picture. So you have to go through the clinical scenario as well and the history of the patient before coming to the final diagnosis. Now, this is my own patient. You can see this patient presented with memory loss and then a unilateral Parkinsonism, severely rigid limb, unilateral involvement, and there is dystonia of the limbs, apraxia. That means the patient is not able to understand whatever he is able to, whatever he puts in the hand. Suppose if you are giving a coin in the hand, he is not able to find out whether it's a coin or a pen on closing the eyes. So he's having limb apraxias, myoclonus, dystonia, and memory loss and Parkinsonism features. So this unilateral severe Parkinsonism with the cortical findings, we call it as corticobasal ganglionic degeneration or CBGD. So here you can see this is the classical finding. You'll have asymmetric parietal lobe atrophy. So you can see there is complete full temporoparietal region, but you can see there is atrophy here. So unilateral or asymmetric atrophy is the classical finding in corticobasal ganglionic degeneration. Now vascular PD, again lower body Parkinsonism. So when we see lower body Parkinsonism means the saccade of the patient is normal. There is not much of mass species. Upper limb is okay. When you do the examination of the upper limb, is able to move the limbs properly. There is no slowness, no bradycardia. But when you look in the lower limbs, the patient is unable to walk. The gait is short stepped, or there is fumbling of the gait. The patient is walking in an ataxic manner, and there is having difficulty in walking, difficulty in turning, etc. So this is called as lower body Parkinsonism. So whenever you see lower body Parkinsonism, two conditions should come into the mind. One is vascular Parkinsonism. Second is normal pressure hydrocephalus. So these two conditions can be picked up easily by the MRI scan. So if you look at the vascular Parkinsonism, so you can see this patient again with lower body Parkinsonism, you can see there is confluent, this is an axial image T2 sequence. So you can see there are confluent lesions involving the periventricular area. This is a coronal sequence T2 flare image. And then you can see there are multiple white matter lesions. So if you get this sort of severe white matter involvement, then you can fairly diagnose a case of vascular Parkinsonism. Now, this is a patient who had severe falls. So this patient was having difficulty in walking and then was falling backwards. And especially while climbing downstairs, the patient had falls. Some memory involvement was there, some frontal signs were there, mild bladder involvement, slurring of speech, some bulbar involvement. So this is not typical Parkinsonism. This is atypical Parkinsonism. And one of the common atypical Parkinsonism which we see is PSP. So that is called as progressive supranuclear gaze palsy. So in this condition, again, MRI becomes very valuable. So this patient, you should not do a CT scan. You should do a MRI scan. And whenever you send the request to the radiologist, you have to write that MRI, and then you are suspecting a atypical Parkinsonism like progressive supranuclear gaze palsy, PSP. So then the radiologist will look into specific features and specific indices in the MRI, which will be helpful in the diagnosis of the condition. For example, you can look here. So in the PSP, there is vertical gaze palsy. Now we all know that the vertical gaze is controlled by the midbrain. So when there is midbrain atrophy, you will get the vertical gaze palsy, especially the down gaze palsy. So you can see, so this is the midbrain, this is the pons, and this is the medulla, and then you are having the spinal cord lower down. This is the cerebellum. Okay. So you can see here in the midbrain, there is atrophy in the upper part of the midbrain. So there is the loss of the fullness of the midbrain is there, and that gives rise to a beaking appearance. So this is called as a hummingbird sign. So you can see the midbrain atrophy gives rise to the hummingbird sign. And this is the axial view, and you can see there is atrophy of the midbrain here, and then you get a sign which is called as the Mickey Mouse sign. And just lower down, higher up, you'll get the morning glory sign. So this is called as the morning glory sign. So the three classical signs which you can find in PSP is the hummingbird sign, the Mickey Mouse sign, and the morning glory sign. So this can be looked for in the MRI. And there is something called as a pons midbrain ratio. So you can look at this. So normally the pons, this is the pons, it's a bulky structure, and then this is the midbrain. So what happens is, in PSP, the midbrain is atrophied and the pons is maintained. So the pons midbrain ratio becomes more. So normal value is 0.24. So in PSP, the midbrain to the pons ratio. So you see that the midbrain becomes atrophied and the pons is larger. So the ratio becomes less. So 0.24 is the normal value, and in the PSP, you'll get 0.12. So it becomes 50%. So that is called as the pons midbrain ratio. And one important index which you can, if you can give the provisional diagnosis in the request of the MRI in case of Parkinsonism, if you are writing PSP, then the radiologist can look for this index also, which is called as the MRI Parkinsonism index, in which you are having the pons and the midbrain ratio, and which is multiplied by the middle cerebellar peduncle and the superior cerebellar peduncle width. So these ratios multiplied, if it is more than 13.55, it is again suggestive of a progressive supranuclear gaze palsy. So you can look at this. So you'll take the pons midbrain ratio and the ratio of the superior cerebellar peduncle, this width, and the middle cerebellar peduncle, and they'll have a ratio. And then if the ratio is more than 13.55, it is suggestive of PSP. Now you would ask, why should we take all the pain to do all these indices and try to diagnose perfectly? Because the treatment is the same. The importance is prognostication. So once we know that Parkinson's disease, the patient has a very slowly progressive disorder, and the prognosis is not very grave. But in the case of PSP, the disorder is going to worsen very rapidly, and most importantly, it's not going to be responsive to the dopaminergic therapy. So in that case, you can explain the prognosis to the patient early on, and that will make the follow-up and the treatment better. So that is the importance of using these indices to get a definitive diagnosis. Now, this sign I've already mentioned, which is called as the hot cross bun sign, and there is also atrophy involving the cerebellar peduncles and the cerebellum also. So this is suggestive of MSA-C. This is again a classical hot cross bun sign, and you can see there is a putaminal slit sign, and this is the gradient sequence. You can see there is some iron accumulation also, which gives rise to the hypointensity in between the hyperintensity, which is seen in MSA-P. Now, CBGD I have already mentioned. You can see there is asymmetrical atrophy involving the left side compared to the right side. You can see the Barre and the sulci here. Here you can see the sulci are very prominent and there is atrophy. Now coming to MRI in mitochondrial disorders, Leake's disease, you'll have bilateral basal ganglia involvement and the midbrain involvement, and also involvement of the olivary nucleus and also the midbrain. So this classical feature is seen in Leake's disease, which is again a progressive mitochondrial disorder. So next we'll go into dementia. So we have covered basal ganglia and then Parkinsonism. So we'll go into the dementia. So what is the use of MRI in dementia? We all know that dementia is a clinical diagnosis. We use the criterias, and then we are having the, we should have the memory loss, we should be recent memory loss, we should have executive dysfunction, we should have apraxia, akinesia, and all those things. And the symptoms should be there for 6 months, and then you call it as a dementia. But now we should know that there are a lot of mimickers which can look like dementia clinically, but you'll be surprised at looking at the imaging. So that is the importance of using imaging in the case of dementia. So the imaging, basic imaging which is required is CT scan. However, MRI scan can help us differentiate various type of dementias and exclude certain disorders which can be missed in the CT scan as well. So the primary things which we have to rule out is a subdural hematoma, which is a very important mimic. Any patient with a rapid onset dementia, Parkinsonism, elderly patient with some headache or without headache, you should always rule out subdural hematoma because it's a great mimicker. Tumors, sometimes diffuse infiltrating tumors involving the basal ganglia, gliomatosis, and the lymphomas, etc., cannot present, usually may not present with headache or focal neurological deficit. So they may be presenting with some memory loss and then Parkinsonism features. So that tumors you have to rule out, and then hydrocephalus, which can again present with Parkinsonism, memory loss, and all those things. So these are the secondary causes which you rule out by doing a scan. Now you will say that the report of the MRI or CT scan of patients with dementia is cortical atrophy. So what else do you find? That is there. Final stage of all dementia, you will have cortical atrophy, which will be diffuse. But the most important thing is, where did the atrophy start? Which part of the cortex you are having preferential atrophy? So that will tell us what dementia the patient is having. Suppose if you are having a medial temporal atrophy and parietal atrophy, it will be likely to be Alzheimer's disease. If you are having a frontal lobe atrophy and a asymmetric temporal pole atrophy, it is likely to be a frontotemporal dementia. If you are having global atrophy with vascular changes, diffuse vascular lesions or lacunes or strategic infarct, it is likely to be vascular dementia. And if you are not having a definite pattern, it could be Lewy body dementia. Now we are having advanced imaging like PET scan, SPECT scan, and all those things, which I will not be covering in this session. So they are the advanced imaging which can be helping us in the functional aspect of the brain, which may again be used along or after the MRI scan if the diagnosis is not clear in differentiating the various types of dementias. Now the MRI, you can have the global atrophy, focal atrophy, and then the vascular disease. So these three things you have to look for, whether the atrophy is diffuse, whether it is more in some part, and what are the vascular changes. So these are the things we have to look for. So Alzheimer's disease, you will have hippocampal atrophy, temporal atrophy, and frontotemporal dementia, you will have more of temporal and frontal atrophy and less of hippocampal atrophy. And Lewy body dementia, usually not much of atrophy is seen. And vascular dementia, you will have a lot of vascular changes. And Alzheimer's, it will be temporal and parietal, while frontotemporal, it will be frontal and temporal, which will be asymmetric. So you can look at the images in frontotemporal dementia. We know that frontotemporal dementia is a spectrum disorder. So you'll have the behavioral variant of frontotemporal dementia, where more of frontal involvement will be there. You'll have the language variant. You'll have in the language variant, you will be having the semantic variant and the non-fluent or the logopenic variant. So a lot of variants are there, and in each of these variants, there is classical MRI finding, which can help us to find out which variant the patient is having. Grossly, that much is not required for clinicians. In our busy practice, it is not much required, but at least you should look for asymmetric temporal lobe atrophy. You can see this temporal lobe is fine, and you can see there is asymmetric involvement of this temporal lobe. You can see this right temporal lobe and the left temporal lobe. So there is asymmetric involvement of the left temporal lobe. So this asymmetric temporal atrophy along with frontal atrophy, if you are getting with sparing of the hippocampus, not much involvement of the hippocampal complex, then you think that the patient may be having a frontotemporal dementia. And then the history is again important. If it's a FTD, the patient will be having behavioral problems, language problems first, followed by memory loss, which is later on. While if it's an Alzheimer's disease, then it starts with memory loss first, which is recent memory loss, and then gradually there will be behavioral problems and other symptoms like apraxia, language problems, etc., which occurs later on. So the tempo of the sequence or the temporal profile of the symptoms are most important when you diagnose cases of dementia and Parkinsonism. So MRI, I'll be just rushing through as we are getting late in time. So one, you are having the global cortical atrophy score, and second is the medial temporal lobe atrophy score, and third is the Fazekas scale for white matter lesion. So what is this? One is global cortical atrophy. So you can score as 0, 1, 2, 3. 0 is no cortical atrophy, 1 is mild atrophy, 2 is moderate atrophy and volume loss of the gyri, And 3 is knife blade atrophy, where we are having severe atrophy, that is grade 3. And MTA score is again the medial temporal atrophy score. So I'll show you this score. So that is based on the width of the choroid fissure, width of the temporal lobe, and the height of the hippocampal formation. So you can go through this. So there is score of 0, 1, 2, 3, and 4. So that is medial temporal lobe atrophy score. So based on this, you can score as whether it's a score of 1 to 4. So 4 means severe and 1 means mild. So what do you mean by this? So this is the axial view. This is the coronal view of the T1 weighted image. Now you can look at the structure. So this is the medial temporal lobe. Okay. And here you are having this S-shaped structure, which is called as the hippocampus. So this is the hippocampus, and this is the choroidal fissure. So based on the volume of the medial temporal lobe, the hippocampal size, the size of the choroidal fissure, you can grade it as the medial temporal lobe atrophy score. So this score is being used, and it is highly specific for Alzheimer's disease, and 100% of the patient with Alzheimer's disease will have a very high score of the medial temporal lobe. So this you can see here, the temporal profile. This is at the onset of the scan. You can look at the hippocampus. It is a rounded, nice rounded structure. At 18 months, if you do the serial imaging, you can see that the hippocampal volume has reduced. And at 36 months, you can see the hippocampal volume is very less. And then the choroidal fissure height is also increased. So the fissure becomes very large and the hippocampal volume reduces. Similarly, if you look at the medial temporal lobe, the volume of the medial temporal lobe also reduces as you follow up this patient. So the follow-up scans may also sometimes be important, especially in research purposes, not in the clinical practice. Now coming to Fazekas score, which is a very common scenario, Fazekas score. So I think we should be knowing this. So there are 3 scores. I'll be just showing the picture. So this is a T2 weighted image, flare image. So you can see few isolated white matter lesions. Here you can see here in the subcortical areas. So this is Fazekas grade 1. So you see a lot of patients with diabetes, hypertension, old age, and when you see this small isolated lesion. So this is Fazekas grade 1. Usually this patient will not have any symptoms. Now you look at this grade 2. There is some confluence in these lesions. The lesions are getting fused. So here again, you see the lesions are fused. Here there is fusion of the lesions, multiple lesions. So this is grade 2 lesion. And grade 3 means there is surrounding involvement of the periventricular area. You see a lot of lesions around. So this patient, grade 2 and grade 3, they will be having a lot of issues like memory loss, subcortical dementia, gait problems, balance problems, urinary symptoms. So this is, we call it as vascular Parkinsonism and vascular dementia. So which is a subcortical dementia. Unlike the Alzheimer's disease and the other type of dementia, which is cortical dementia, here you are getting a subcortical dementia in the white matter lesions. Now, strategic infarcts. So it is not needed that you should have these white matter lesions always to get the vascular dementia. Sometimes certain lesions in certain places can give rise to a lot of memory issues, especially if they are in the association areas or areas like thalamus, etc. So these are the various crucial areas where you can have a lot of memory issues. One is the middle cerebral artery territory, then posterior cerebral artery in the paramedian thalamus, inferior medial temporal lobe, because the memory and all the processing occurs there. Watershed infarction involving the superior frontal and the parietal areas, and thalamic involvement. So you can see this patient has thalamic, bilateral thalamic involvement, and this patient has dementia. So he is having subcortical dementia, he is not able to speak, not able to understand. So this is called as thalamic dementia. So this is again common. Then this is a right paramedian infarction, again involving of the medial temporal lobe, etc. So this can also give rise to a lot of cognitive defects. So to call as vascular cognitive impairment, you should have onset of cognitive deficits after the stroke. There should be or decline in the cognition, gait disturbance, urinary symptoms, personality, mood changes, plus imaging evidence. So what imaging evidence? There should be large vessel infarction. There should be strategic strokes either involving the thalamus or the medial temporal lobe, etc. There should be multiple lacunes or extensive confluent white matter lesions. For example, there should be white matter extensive lesions, or strategic lacunar infarcts involving the thalamus, or large cortical infarcts like this involving the parietal lobe and the temporal lobe, or the medial temporal lobe, and such infarctions. So if you get this imaging along with dementia and the other clinical feature, you can definitely say it's a vascular cognitive impairment. Now coming to normal pressure hydrocephalus, we see a lot of patients who come with the classical triad. So what is the triad of normal pressure hydrocephalus? It is dementia, urinary involvement, and a wide gait. So we classically call it as the magnetic gait. They'll be having a short step gait as if they are glued into the floor, and they'll be walking very slowly. So that is the classical magnetic gait of normal pressure hydrocephalus. Dementia usually occurs late. First symptom will be gait abnormality, followed by urinary symptoms, and then dementia. Dementia is subcortical dementia. It's not a cortical type of dementia. So you can see the CT scan picture. You can see there is now a nice rounded ventricles and taut ventricles bilaterally. Here again, you can find this. And in such cases, it can be confusing because sometimes the normal pressure hydrocephalus may be associated with a lot of vascular changes, and atrophy may also be there. So it becomes quite difficult to see whether this is giving rise to the symptoms. So in that case, this index, that is the Evans index, may be helpful. You can take a ratio of the bifrontal distance as well as the inner, from the inner part of the cortex. You can take the maximum width, and the ratio of it is greater than 0.3, then it is likely to be due to the NPH. Then second thing is you can look at the ventricular ooze. So you can see the periventricular ooze is there. And one important finding is there is something called as DASH. So that is disproportionately enlarged subarachnoid space, hydrocephalus. So this is called as, there is a subarachnoid space which is disproportionately enlarged. So this is called a DASH. And you can see the ventricles are tautly, it is taut, very taut, and there is periventricular ooze. And you can look at the angle also. So usually the angle will not be very wide. So if the angle is not very wide, then you can say that this is likely to be the normal pressure hydrocephalus. And there are new sequences like the CSF flow study, so which can again be used in the MRI, which can be helpful in detecting normal pressure hydrocephalus. However, sometimes despite of all the investigations, it may be quite difficult to find out. So in that case, you can use a CSF tap test, which we do clinically, and then that will tell us whether the patient is having a significant component of the hydrocephalus or not. Wilson disease, again a very common condition, basal ganglia involvement, and you can see the classical giant panda sign which is seen in the brainstem. So that is again seen in the Wilson disease. There is one more sign in the pons which is called as the miniature panda sign, which can again be seen in Wilson disease. So you look for that. Now coming to the pituitary anatomy, shall I proceed or should I stop? I think I've crossed 1 hour.
I think, sir, আজকের জন্য enough. 1 hour is okay. আমরা question answer নিব তো?
Okay. So because I'm having 2 more topics, so I think it will.
How much time will it take?
It will take a lot of time, I think, ma'am. Maybe 30 minutes.
Madam, 1 hour হইছে এখন আমরা ম্যাডাম thank you very much Dr. Praveen Kumar Yadav, as usual আপনার all the presentation brilliant হয়, আজকেও তাই। তো আমি question answer পর্বে যাবার পূর্বে আমাদের আজকে চেয়ারপারসন ম্যাডামকে আপনার সার্বিক সেশন সম্বন্ধে কিছু কমেন্ট করা আহ্বান জানাচ্ছি। প্রবীণ স্যার, আপনি স্লাইড মোস্ট অফ করে দেন, এখন স্লাইড শেয়ারটা অফ করে দেন।
Thank you very much for the wonderful and elaborate presentation indeed, mostly on the basal ganglia lesions, and he covered the dementia and other thing. So something I have noted that MRI evaluation in case of toxin metabolic demyelination, and that is he very beautifully presented how to differentiate the pecan from the non-pecan, and whereas some of them showing the cavitation while associated with ceruloplasmin, and non-ceruloplasminia or aceruloplasmin associated with no cavitation indeed. And while talking about the HIE, I want to mention something about the HIE. That is, there are some 3 grades about HIE: mild, moderate, and severe. And in some cases of to evaluate the HIE as early as possible, the possibility to revive the patient is very, I should say, amazing. The patient would revert if I diagnose HI early. And there is an increased incidence of ultrasound for the evaluation of HI, especially it is called the Doppler CAD, color Doppler index evaluation. And some of the machines of the modern ultrasound, like the Philips one, like the Toshiba, they have this software. And so that within 6 hours to 12 hours, they can diagnose the early HI. And if oxygenation, hypothermia, and the necessary measures can be taken, the patients can be totally benefited and reversed. And there are some studies to evaluate low dose, that is early HI by low dose CT. Low dose CT around 60 to 80 kVp. If evaluate can be done within 24 hours or 48 hours, it can evaluate the HI too. And number 3, the MRI. At most of the patients, while we get the HI patients, are from moderate to severe HI, because the sign symptom, children cannot speak themselves. And in this subcontinent, the parents and the relatives are also not that much concerned to take the thing that they have many times they have the history of prolonged labor, and they are not taken to the hospital, and they eventually miss this history. And when the child suffers from moderate to severe, then they come to the hospital. And in MRI, we clearly differentiate the mild, moderate, and severe HIE. And there are specific signs, and most of the HIE patients, they are associated with the craniostenosis. And you have talked another thing about the tumor, about the tumor and hematoma. Okay, and it's the most important thing of MRI is diffusion weighted image, which picks the cytotoxic edema. So you got the cytotoxic edema in case of a tumor, you got the cytotoxic edema in case of hemorrhage, in case of any type of lesion, it is possible. So how to differentiate? So you have Praveen also told us that gradient echo. Now, this sequence is called the susceptibility weighted image, or SWI. And all the current MRI machines from 1.5 Tesla to 3 Tesla, they have the susceptibility weighted image. So I will tell the neurologists to advise, though all the centers in Bangladesh do not regularly use it, but it is a very useful thing to differentiate the tumor from the hemorrhage, because some of the tumor shows diffusion restriction in DWI. That is, the tumor shows hyperintensity in diffusion weighted image, as well as the hematoma shows hyperintensity in diffusion weighted image. So how can you differentiate? So simply, if you advise SWI or susceptibility weighted image, it shows extensive blooming, which shows the degradation product of hemorrhage. So you can differentiate it easily. And another thing is also in concern that MRI can delineate very beautifully the stages of hemorrhage, which Dr. Praveen already told, that from early hemorrhage, early subacute, late subacute, early chronic, and chronic. And they have a peculiar rim of hemorrhagic degradation product that is hypointense, and within which there is restricted diffusion, that is hyperintense. So sometimes it creates a problem, and some of the physicians send it to the radiologist to do an MRS, whether it is a tumor or it is hematoma. Actually, the answer is simply the SWI or simply a CT scan can do it. And we know, moreover, there is a role of contrast in subacute hematoma or subacute infarct. If we give the contrast, then in subacute stage, it shows rim enhancement. Another thing about the osmotic demyelination, Praveen told that central pontine myelinolysis, yes, it is almost always involve the central pons, and whereas the infarcts involve the paramedian part of the pons and other things. And how to differentiate Huntington's disease. It is an important thing, but I should say most of the thing is the sign symptoms are totally diagnostic. Huntington's chorea and the typical finding is the clinical feature suggests that it is a Huntington's disease. And otherwise, MRI help to see the putamen atrophy and other signs. And about the toxoplasmosis, yes, it is only involved in case of immunosuppressed. Most of the cases are immunosuppressed patient. Okay, now an important thing, and it helps in both in COVID era, that is the cerebrovascular thrombosis. So MRV is the choice of investigation, and only not the non-contrast MRV, because non-contrast MRV can give some aliasing artifact where falsely we can think that there is a filling defect within the vein and suggest that it is a thrombus, but actually the contrast enhanced MRV is a choice of investigation. And in some cases, CT, moreover, the MRV is very valuable in case to diagnose the large veins like the superior sagittal sinus, inferior sagittal sinus, but to detect the minor veins like the deep veins which supply the deeper structures like basal ganglia, CT venogram is a choice of investigation. And you told about CRJ, Creutzfeldt-Jakob disease. Yes, history is very important because it need to differentiate from the other mitochondrial disorder. And there is, of course, pulvinar ophthalmos and caudate nucleus gives hyperintensity, the typical hockey stick sign. But the one more important thing that neurology should give the history, not simply the just convulsion. While, you know, Dr. Ehsan and Dr. Praveen, in the subcontinent, we got the patient behind the radiologist and telling that, please give the diagnosis, without any history. And while they came just with a page advice that MRI of brain and nothing else, no history, what type of conversion it is, whether he is associated with any type of chorea, whereas any type of anomaly, any other thing. So please supply the proper history. And another thing I have told it, a differentiation of hemorrhage in CT and MRI. So you have given a beautiful analysis and imaging of CBGD, that is asymmetrical atrophy and vascular Parkinsonism. There is giving the beautiful sign. And in PSP, you call the 3 sign, that is the hummingbird sign, because due to severe midbrain atrophy in sagittal image, and in Mickey Mouse sign in the axial image, and another is the morning glory sign. That is beautifully described. But I will tell the clinician just to put the history and your suspicion, what is your provisional diagnosis is. That helps the radiologist a lot. And the other thing you mentioned beautifully, that is how to differentiate the normal pressure hydrocephalus from other hydrocephalus, that is from the ratio. If the ratio is more than 0.3, or there is periventricular seepage, and you know where seepage occurs, and in addition, DESH. And the thing you showed in coronal MRI, that is a specific protocol we use, that is called the epilepsy protocol. So when we search for the Alzheimer's disease, or we search for the hippocampal atrophy or hippocampal volumetry, whatever you do, to see the medial temporal atrophy, we need to do the specific protocol, that is the epilepsy protocol. It needs a different orientation. So you need to mention, I will advise the physician to mention this in their advice. And I want to add one thing, that in case of medial temporal atrophy, there is also, there are differential diagnosis may be low-grade glioma. So how will you differentiate a case of Alzheimer's disease, initial case of medial temporal atrophy from low-grade glioma? Because both of it, some volume reduction is there, and some hyperintensity is there. So if you put contrast, low-grade glioma, in some cases they take minimal contrast, or in some cases they do not any contrast. But if we do the MRS, then it can be differentiated. And these are the things. So as well, it's a very good discussion. I will tell. And now, should we go through the question answers, Ehsan?
Thank you, madam. Thank you, madam. আপনার সুন্দর প্রাণবন্ত আলোচনার জন্য। ও ডাক্তার খুরশিদুল ইসলাম নয়ন জিজ্ঞেস করেছে, আমি টি-শার্টটি কোথায় পেয়েছি? এই টি-শার্টটি আমি পেয়েছি, এটা রিয়াল মাদ্রিদের জার্সি। আমি এটা হচ্ছে রস। হ্যাঁ, তো যেহেতু আমি রিয়াল মাদ্রিদের ফ্যান, তাই এটা পরে বসে আছি। তো আমি কোশ্চেন আনসারে যাচ্ছি। স্যার, ফার্স্ট কোশ্চেন ওভার টু ডক্টর প্রবীণ কুমার যাদব from Dr. Noshin Tabassum. Respected sir, what are the MRI brain abnormalities found in the idiopathic Parkinson's disease? Might have missed it. Thank you.
Hello.
আচ্ছা, শোনা যাচ্ছে?
শোনা যাচ্ছে?
Yes.
জি স্যার।
Okay. See, idiopathic Parkinson disease, actually you need the 3 Tesla MRI. Okay. So 3 Tesla MRI, what we do is you can find out the substantia nigra in the midbrain. It is seen as a hyperintense, it's seen as a dark signal there. So in the 3 Tesla MRI, if you look at the substantia nigra, you can find out the loss of the hyperpigmentation in the substantia nigra in 3 Tesla MRI. So that may be an early finding of idiopathic Parkinson disease. So that is there, but you have to do a very high quality image to find out the substantia nigra hyperintensity. So usually in the routine 1.5 Tesla, it is quite difficult to delineate. So that is one thing which has come up. Now, second thing is you can do a TRODAT scan or a SPECT scan. So that is a dopamine transmitter imaging. So with that, you can find out the asymmetric reduction in the dopamine. So that is also helpful. So these two things you can use to find out idiopathic Parkinson disease.
Thank you, sir. Next question from same person. আমি দুইটা কোশ্চেন একসাথে করছি। Sir, how we can diagnose CNS lymphoma by MRI? Next question, what are the findings of Wilson's disease in MRI of brain? আপনি মেনশন করেছেন, তারপর আরেকবার যদি একটু বলেন।
So the CNS lymphoma, the classical finding is it involves the periventricular areas. So the MRI, if you get a periventricular lesion, which is involving the periventricular part, and then it may involve the corpus callosum also. And it will be, since it's a highly cellular lesion, so it will be hyperintense in T2, but there may be some hypointensity which may be there. And diffusion restriction, there will be brilliant diffusion restriction. So because of the high cellularity, there will be diffusion restriction, and contrast enhancement will also be there. So if the patient is having a lymphoma. Now, if the patient is immunosuppressed, the contrast enhancement may be absent. Or if the patient is having some sort of immune reconstitution, contrast enhancement may be absent. But a periventricular location with involvement of corpus callosum with diffusion restriction and a MR spectroscopy showing a choline peak, a high choline peak, may overall summarize the finding of a lymphoma. You can also do a MR perfusion image, which will show high perfusion, hyperperfusion in that area. So that is again important in lymphoma. While in toxoplasmoma, it may be absent. The perfusion will be not there. And hemorrhage may be more common in toxoplasmoma, while hemorrhage is unlikely in a lymphoma. So with these features, you can differentiate lymphoma.
Wilson's disease. What about Wilson's disease?
Wilson disease, classically two signs are described. However, in clinical practice, what I have seen is I am having some 15 to 20 patients of Wilson disease in my follow-up. So most common finding is basal ganglia hyperintensity. So they'll be having this caudate and globus pallidus and putamen hyperintensity, which is most commonly seen. But the classical signs which has been described is the face of the giant panda sign, which is seen in the midbrain area, and the miniature giant panda sign, which is seen in the pons. So the face of the giant panda sign, you will have the sparing of the red nucleus and the lateral midbrain. So they will have the dark spot. So the red nucleus is spared, so that will give the eyes and the ears, the spared area will be giving, and the hyperintense spot will be the bright spot around that. So dark followed by bright, and the ears will give the darkness. So all together gives rise to the sort of giant panda like face appearance, which is seen in Wilson disease.
Thank you, sir. আপনি অলরেডি এই কোশ্চেনটার আনসার করে ফেলেছেন। আমাদের একজন ডাইনামিক
আমি একটু অ্যাড করতে চাই
ম্যাডাম আমি কোশ্চেনটা করে নেই। হাউ জায়ান্ট পান্ডা সাইন ফর্ম ইন উইলসন ডিজিজ, উড ইউ প্লিজ এক্সপ্লেইন ইট উইথ এমআরআই এগেইন? এই কোশ্চেনটা আরেকজন করেছেন, এই জন্য আপনাকে স্যার আমি আরেকবার মেনশন করলাম।
You need to go to the slide, huh?
Yeah, 1 second. I'll just get the slide.
By this time আমি একটু অ্যাড করতে চাই, সেটা হচ্ছে পার্কিনসনিজমে যে রেড নিউক্লিয়াস আর হচ্ছে যে সাবস্টেশন অ্যাগ্রা, এটা হচ্ছে নরমালি যেটা সিগন্যাল দেয় পার্কিনসনিজমে, সেই নরমাল সিগন্যালটা লস হয়ে যায়। হ্যাঁ, তো এখন তার জন্য কি হবে, তার জন্য হচ্ছে যে হাইপার ইন্টেন্সিটি হবে আর কি। এসডব্লিউআই তে হাইপার ইন্টেন্সিটি হবে। সো এসডব্লিউআই তে যে নরমাল সিগন্যাল ইন্টেন্সিটি থাকবে ওখানে আয়রন ডিপোজিশনের জন্য বা কি বলে এটাকে মেটাল ডিপোজিশনের জন্য, সেটা হচ্ছে লস হয়ে যাবে ইন এসডব্লিউআই। তো এটাও একটা খুব চমৎকার ফাইন্ডিং, এবং এটা এই জিনিসটা কিন্তু শুধু থ্রি টেসলাতে যে সম্ভব তা না, এটা আমরা নর্মাল ইয়েতে 1.5 টেসলাতেও দেখতে পারি। আর মোস্ট ইম্পর্টেন্ট বিষয় কি, যে আমাদের একটা ধারণা আছে যে থ্রি টেসলা 1.5 টেসলা, এটা 1.5 টেসলাতে এটা পসিবল না, কিন্তু থ্রি টেসলা পসিবল। আসলে নাম্বার অফ চ্যানেল হচ্ছে ইম্পর্টেন্ট। 1.5 টেসলাতেও যখন আমি একটা 4 চ্যানেল এমআরআই চাইতে আমি যদি 18 চ্যানেল এমআরআই দিয়ে করি অথবা আরো বেশি আপগ্রেডেড চ্যানেল এমআরআই দিয়ে করি, তখন যে রেজাল্টটা আমি পাবো সেটা কিন্তু থ্রি টেসলার মোটামুটি একটা 64 চ্যানেল অথবা হচ্ছে আরেকটু কম চ্যানেলের কাছাকাছি পর্যায়ে যাবে। সো এটা একটা বিষয়। আরেকটা কোয়েশ্চেন যেন কি ছিল, লিম্ফোমা। আচ্ছা, লিম্ফোমাতে যেটা আমি আরেকটু অ্যাড করতে চাচ্ছিলাম সেটা হচ্ছে যে লিম্ফোমাতে হলো যে ফিচারগুলো বলেছেন ডক্টর প্রবীণ, দ্যাটস ভেরি গুড। T1 হাইপো, T2 হাইপার ইন্টেন্স অ্যান্ড ইরেগুলার প্যাচি এনহ্যান্সমেন্ট, তার সাথে হচ্ছে অন্য ইমেজিং গুলো করা যাবে। এছাড়া লিম্ফোমাতে হচ্ছে এমআরএসটাও খুব ইম্পর্টেন্ট। এমআরএসতে হচ্ছে ভেরি হাই কোলিন আসবে এবং কোলিন ভার্সেস ক্রিয়েটিনটা অল্টার্ড হয়ে যাবে। এটাও একটা ফিচার। থ্যাংক ইউ।
Dr. Praveen sir.
So you can see this image. So this is the image. So you can see this is the red nucleus.
Image টা একটু ওপেন করেন স্যার।
হ্যাঁ, ইমেজ ওপেন হয়নি, শেয়ার হয়েছে।
You need to share the screen.
Is it visible now?
Yes.
Yes, sir.
Okay. So if you look at this sign, so this is the classical sign which we see in commonly, that is the basal ganglia involvement, and this is called as the face of the giant panda sign. So you can see there is hypo intensity. So this is the normal red nucleus here. So there is pairing of the red nucleus, which gives rise to the eye of the panda, and then the this part of the midbrain is paired here. So that gives rise to the mouth of the panda, and this pairing of the lateral part, so that is the around the crus cerebri and this part, that gives rise to the ear of the giant panda. So this is the ear, this is the eye, and this is the mouth, and there is hyper intensity in between. So there is involvement of the other parts. So all this appearance together gives rise to the it looks like a face of the giant panda. So that is the imaging finding. So this is the eye, this is the mouth, and these are the ears.
Thank you very much, sir. আপনি এখন ক্লোজ করে ফেলতে পারেন স্যার। আমরা নেক্সট কোশ্চেন দিব। নেক্সট কোশ্চেন স্যার, অনেক কোশ্চেন from Dr. Mehnaz Firdos. Sir, how can we differentiate diffuse axonal injury from diffuse cerebral edema? What can be the hard sign of CVST in MRI?
Diffuse axonal injury is usually a sequelae to the trauma. So whenever there is traumatic brain injury, then we get the diffuse axonal injury. So what we can see in the diffuse axonal injury is, one is there will be multifocal involvement of the brain. And if you look at the T2, the gradient echo or the susceptibility weighted image, you will get micro bleeds around. So all around micro bleeds, if there is there, and if there is multifocal CNS involvement, and the diffusion may also show some diffusion restriction in the microbleed areas. So these three will mark that there may be diffuse axonal injury, and then the patient also. So patient should have altered mentation, and the patient will be having abnormal sensorium. The GCS will be low, and there is no structural injury to the brain, like there is no SDH, there is no large hematomas, no bleed, which is explaining the low GCS. And you are seeing this micro bleeds, multifocal CNS involvement, then we think that it is likely to be a diffuse axonal injury. And the second question is diffuse cerebral edema. So yes, diffuse cerebral edema will be diffuse involvement of the brain. There will be loss of the gyral patterns will be there. The gray-white matter differentiation will be lost, and it will be diffuse involvement. So it's a totally different picture from diffuse axonal injury. And the GCS of the patient will again be low in diffuse cerebral edema as well. Now, clinically, and then in the blood, you can do the neuron-specific enolase, which is there. So, which is a diffuse axonal injury, then usually the NSE levels will be high. And similarly, in hypoxic brain injury also, the NSE levels may be high. So, with all the parameters, you can differentiate.
Sir, arekta question chilo, sir. What can be the hard sign of CVST in MRI?
Okay, CVST means cerebral venous thrombosis. I think they are saying. So CVST can occur in multiple ways. So it depends upon the location of the CVST. Now, if it's a sagittal sinus thrombosis, then the hard finding will be bilateral frontal edema and swelling of the frontal part of the brain. Clinically, patient will have altered mentation, seizures, and focal neurological deficit. There may be involvement of the lower limbs more than upper limbs, and papilledema and all those things may be there. MRI will show you will see the edema, and then you may be seeing a filling defect in this superior sagittal sinus. You can make it out in a normal MRI also. In the T2 weighted image, you can see the filling defect. T1 also, you may be seeing the thrombus. And if you do a MR venogram and gradient also, gradient sequence also, you can make out the thrombus sometimes. And MR venogram, you can see the blockage. Now, if you go to the lateral sinus thrombosis, that usually presents with headache, altered mentation, and seizures. And there may be some unilateral deficit in the opposite side, and you will get a hemorrhagic infarct. So there may be hemorrhage and infarct, both of the lesion, and hemorrhagic component may be there. And if you look at the T2 weighted image, again, you can see the thrombus in the vein, or you can use the T1 sagittal image. So that may again show the thrombus. And if it is not there, you can do the venogram. So that will show the thrombus. Sometimes the problem with the venogram is that is why madam mentioned that you should do a contrast venogram, because if you do the TOF venogram or other venograms, so you will get you may get a hypoplastic transverse sinus, which is very common in clinical practice. So it's very difficult to find out whether there is a thrombus or whether it is hypoplastic. So then you have to do a contrast venogram, and you can do the T1 sagittal image also to look whether there is a thrombus. So with that, you can find that. Now, if it's a deep venous thrombosis, then it becomes really difficult. Then the patient will actually be comatose, and then papilledema, comatose, and sometimes seizure may be there. And you may see bilateral thalamic swelling and thalamic lesions. And in that case, you have to do the MR venogram, look for the straight sinus and the deep veins, the vein of the Galen and all those stuff. And also the CT venogram, which madam has mentioned. That CT venogram you can do in that situation. It's a deep venous thrombosis. So these are the various ways the venous thrombosis presents.
Chairman, Madam, কি
I
share করবেন?
want to add, yeah, thank you. I want
Sure,
to
madam.
add with Praveen that to differentiate the what is the diffuse axonal injury from the cerebral edema. Diffuse axonal injury may not be associated with cerebral edema. So the sulci gyri are normally oriented. You will not show any effacement there, but in diffuse cerebral edema, the sulci are effaced, and the gray-white interface is obliterated. Normal gray-white interface is not there, while in diffuse axonal injury, the interface is maintained. And other things are same. And in case of diffuse cerebral edema, we see the effacement of extraventricular CSF spaces, whereas in the case of diffuse axonal injury, we do not get. And in addition, as there is history of trauma in diffuse axonal injury, sometimes we may get brain herniation. That is displacement of the pons or herniation of the midbrain. Associated herniation may be there. Okay, thank you.
Thank you, madam. বেশ ইন্টারেস্টিং একটা কোশ্চেন from Dr. Farjana Sultana. Sir, can we initiate treatment of a patient seeing MRI finding of Parkinson's disease in absence of any clinical symptoms? এটার উপর স্যার আমার কাউন্টার কোশ্চেন হচ্ছে যে ক্লিনিক্যাল সিমটম ছাড়া কি এমআরআই তে পার্কিনসন চেঞ্জ আসতে পারে? প্রবীণ স্যার।
See, first of all, you have to understand with the advent of imaging, we may be doing a lot of scans and all those things. But I think without clinical features, the diagnosis of Parkinson's disease is clinical. So the diagnosis, the patient has to have all the clinical features like I've already mentioned in the previous sessions. Bradykinesia should be there, tremor should be there, slowness should be there, and the movement should be slow, change in handwriting, masked faces, all those things should be there, and it should be affecting the quality of life of the patient. So if a Parkinson's disease just comes with mild tremor, it's not needed to treat that patient at that point. You leave the patient alone. You say that you come in follow up. If it is affecting your quality of life or your work or profession, then only you are going to get treated. So if you are seeing even the clinical features, it doesn't mean that you have to treat the patient. So only if it is affecting the quality of life, then you have to treat the patient. Now coming to the imaging. Now, if there is no clinical correlation to the imaging finding, there is absolutely no role of starting the treatment at that point. So I don't think you should give the treatment without clinical features. So you have to treat the patient. Yeah.
Thank you, sir. Dr. Rashiduzzaman একটা কোশ্চেন, এটা আমি চেয়ারম্যান ম্যাডামকেই করি। ম্যাডাম, হাউ টু ডিফারেন্সিয়েট ডিমেনশিয়া of Alzheimer's and that of vascular origin, both clinically and radiologically? Hello?
হ্যাঁ, এখন শোনা যাচ্ছে?
হ্যাঁ,
clinical portion of dementia যেটা এটা তো আগেই it was previously discussed by Praveen, and how to differentiate vascular and Alzheimer's disease. Okay,
radiologically, madam. I will
give an emphasis on that. And in Alzheimer's disease, he previously showed you that predominantly it involves the temporal lobe. And in temporal lobe, there may be hippocampal reduced volume of hippocampus. Initially, there will be, he showed that medial temporal atrophy or something like that. And there is initially the hippocampal intensity will vary. And there are some index. We can measure the intensity of hippocampus. If a physician suggests, then by measuring it, it can be assumed that there is some changes in the hippocampus. Before it is visible that volumetric reduction has happened. And the next stage is reduction of the size of the hippocampus. And there is a uncal hyperintensity and the hyperintensity of the surrounding gyrus, as well as associated parietal and in some cases temporal hyperintensity may be there in Alzheimer's disease. And Alzheimer's disease is also, in addition to the clinical manifestation, there are some advanced imaging that Dr. Praveen told that to see the hypometabolism, we can do the PET scan. So PET can show the reduced metabolism in Alzheimer's disease in temporal lobe or in some cases of parietal lobe. But what in case of vascular dementia? Vascular dementia predominantly involves the thalamus, basal ganglia, paraventricular white matter, deep white matter. And we see there that multiple punctate lesions, and some of the lesions within the thalamus, basal ganglia, paraventricular white matter, and these lesions associated with the other clinical manifestation, we can think about vascular dementia. And while doing the PET scan, so in vascular dementia, there is no substantial that much evident hypometabolism, but in case of Alzheimer's disease, the hypometabolism is totally, it is evident that the hypometabolism involves in the hippocampus as well as a temporal lobe, part of parietal lobe. And the another scan, advanced scan, is available that Dr. Praveen told. That is the DAT scan. That is the deposition of the metabolite within the affected site. So that is also possible in SPECT. Okay, that is the imaging profile.
Thank you, madam.
Can I add in the clinical findings?
Like, sure, you can add the.
Yeah, so vascular dementia, as already told, is a subcortical dementia. So there won't be recent memory loss, and usually the memory loss improves on cues. So suppose if the patient forgets something, if you give them a clue, they will be able to retrieve the memory, because the actual memory is there, but the retrieval is lost because of the subcortical lesions and also the involvement of the basal ganglia. So it's a subcortical memory loss, and the dementia is subcortical. And there will be no apraxia or cortical signs, like apraxia will be not there, executive dysfunction will be less, and bladder involvement will not be there in the early stages of the Alzheimer's disease. While if you take a subcortical dementia or vascular dementia, it will be step-like progression. So they are having a vascular lesion or a stroke, and then the patient deteriorates. Again, there is a plateau and there is a deterioration. So this step-like progression with more of subcortical memory loss, more bladder involvement, more bulbar involvement. And when you examine the patient, then you will get brisk reflexes, extensor plantar, pseudobulbar symptoms like emotional incontinence and all those things. So this combination, if you're getting, then you think of vascular dementia. But if you get pure memory loss and cortical problems, then you think of Alzheimer's disease. So clinically, this is how you differentiate from Alzheimer from this vascular dementia.
Thank you, sir. My last duta question, sir. First question, sir, whether MRI is preferred over CT in diagnosing ischemia in basal ganglia, thalamus. Which one is better, T1 or T2?
See, this question, I think for any ischemia, MRI is the gold standard imaging. Because as we all know, CT scan takes long to detect the acute lesions, and the signs may be very subtle so that it may be missed. So any stroke, if the stroke is within the window period, and if you are planning to thrombolize the patient, the investigation of choice is CT scan. If the MRI, if you are going to take a lot of time, then you do the CT scan, rule out a bleed, and thrombolize the patient. But if the stroke is after the window period, the investigation of choice is MRI scan. In the MRI scan, the best image to detect a stroke, that is infarction, is DWI image. We all know, diffusion weighted image. It will pick up the scan. It will pick up the stroke within almost 15 to 30 minutes of the stroke. So that is the gold standard. However, if it is not available and if you are planning to thrombolize the patient, you can do the CT scan. And T1 and T2 image, I think they are not the gold standard for diagnosing the stroke. T2 flare images, sometimes you can use if you are planning to do a thrombolysis, you can look at the diffusion flare mismatch. So, yes. So if you are having a flare and you are having a diffusion, so the diffusion means the area has already infarcted, and flare means the area which is at risk. So if there is a mismatch, that means you can even thrombolize after the window period, or you can do some other mechanical thrombectomy and all those things. So these two sequences you can use, diffusion and flare, but the gold standard is diffusion images for stroke.
Chairperson, Madam, kichu bolben?
Yeah, one thing I want to add, we have missed, as it is not total lecture about the ischemia. So Praveen possibly hasn't told about the diffusion perfusion study. I think it is beyond today's discussion. But if you want to know about the stroke and the susceptible area of stroke, which is susceptible for more ischemia, so the area of vulnerability or the shadow, that area is detected by diffusion perfusion mismatched perfusion study at first, and diffusion perfusion mismatched study. That is very important. Another thing I want to add, to see the white matter nowadays, diffusion tensor imaging or DTI is another very important imaging parameter, and not only the DTI not only depict the white matter that is distracted or displaced by a tumor or a hematoma or a space of coagulation. Rather, it shows the disorientation, its orientation, its lysis, and every pattern. And it can be done in 1.5 also. 1.5 as well as Tesla machine. DTI is very important in detecting white matter lesion.
Yeah, DTI becomes very important, especially when we are planning surgery for some tumors, etc.
Yeah. Because in Parkinsonism, sometime you need to do the surgery to avoid to operate the temporal lobe or to operate the part of the parietal or part of the frontal lobe. You need to do the DTI.
Yeah. So that in that case, it becomes very important to find out the eloquent areas where the important fibers are passing, so that you can avoid resecting those areas.
Yeah.
Thank you, sir. Aajka last question from Dr. Shivani Prasad Pal. Sir, how to differentiate vascular dementia and normal pressure hydrocephalus?
You mean by clinically or by imaging?
So both angle you can discuss.
Okay, so clinically, like normal pressure hydrocephalus, as I've already mentioned, first symptom will be gait abnormality. The gait abnormality will be a slow gait, magnetic gait. It will be looking like a Parkinsonian gait. However, the base of the gait will be normal white base, and there will be short steps, and the upper limb will be spared. The eye movements will be spared, no masking of the facies. Second will be urinary symptoms like urgency of urination and precipitancy also. And then later on, they will be having a subcortical dementia. So the dementia of NPH and dementia of vascular dementia is almost same. Both of the dementias are subcortical. Now, how do you differentiate? NPH will be a progressive disorder starting with gait abnormality and urinary involvement. While in vascular dementia, you will be having memory loss, which will be subcortical, and you will be having brisk reflexes. You will be having the pseudobulbar symptoms. Bladder involvement will be less compared to that of NPH, and the gait will be not be a magnetic gait. It will be a low. It will be a normal base and somewhat spastic ataxic gait as compared to a magnetic gait in NPH. And the reflexes will be brisk. You may get an extensor plantar, and you will be having a stuttering course. That means there will be sudden worsening and then a plateau and then sudden worsening depending on the new lesions which are arising. So clinically, this is how you differentiate. And imaging wise, I've already told NPH you will be having a disproportionately dilated ventricle with periventricular seepage. And then you will be having the Evans index, which will be more than 0.3. And in the coronal sequence, you can look at the dash, you can look at the angle of the corpus callosum, and atrophy will be less prominent, white matter lesions will be less. And you can do the CSF flow study, which will show the flow voids in the around the aqueduct of Sylvius, which will be quite diagnostic. You can do a CSF tap test in which you can drain out 30 ml of the CSF, and then you make the patient walk and you look at the MMSE and the gait. You can do the 6-minute walk test, and then that will show very good improvement in the case of NPH. While in vascular dementia, I've already mentioned the lesions can be either periventricular lesions, it can be large vascular infarcts, or it can be strategic infarcts involving the thalamus or the medial temporal lobe, etc. So with this, you can clearly differentiate NPH versus vascular dementia, both clinically and by radiology.
Sir, আরেকটা কোশ্চেন স্যার, লাস্ট একটা কোশ্চেন নিয়ে নেই, তারপর আমরা আমাদের চেয়ারপারসন ম্যাডামের কাছে যাব সেশন ক্লোজ করার জন্য। স্যার, ডক্টর রাশেদুজ্জামানের কোশ্চেন, bilateral basal ganglia hypersensitivity, hypertensity, how to differentiate among differentials?
Okay, so that I've already mentioned. The bilateral basal ganglia hyperintensity can occur acutely and then chronically. So that will be depending on the history. So what is the history of the patient, whether it's acute, chronic, what is the clinical feature, what is the sugar level, whether it's a child, whether it's an adult, whether there is any history of trauma, whether there is a history of hypoxia, whether it's a progressive disorder, it's a one-time event. So what is the temporal profile? So entire history is required to find out what it is. And then based on that, you can find out for acute lesion, bilateral involvement, whether it is in the globus pallidus, whether it is in the caudate nucleus, whether it is in the putamen. For chronic lesions, again, you can differentiate depending on the location of the lesions. And then you have to look for susceptibility weighted images, whether there is any iron deposition, whether there is any bleed, and whether the cortex is involved or not. So I think without history, it is a total, we are totally blind. So history plus radiology. So kindly always give the history properly to the radiologist so that they can make out, and you should have a list of differential diagnosis, 3 or 4 differential diagnoses when you give. So it's the clinician's job. And then we'll have the expertise of the radiologist and the finer details, and then compiling both together and the other lab investigations, you can come to a diagnosis. Like otherwise, it's not possible.
থ্যাংক ইউ স্যার। আজকের সেশনে যারা মনোযোগী শ্রোতা ছিলেন তাদের কিন্তু অনেকগুলো ডিজিজও পড়া হয়ে গেল। কারণ স্যার কিন্তু শুধু এমআরআই ডিসকাস করেননি বা কোশ্চেন আনসার করেননি, দেখা গেছে রিলেটেড কোশ্চেনের সঙ্গে সঙ্গে ডিজিজও পুরো ডিসকাস করে ফেলেছেন। আমার তো মানে 7-8টা ডিজিজ রিভিশন হয়ে যাবে অনেকের। আসলে মানে যদিও স্যার খুব ইন্টারেস্টেড ক্লিনিক্যাল কেসগুলো প্রেজেন্টেশন করার জন্য, আসলে এইসব প্রেজেন্টেশন উনি 24 আওয়ার্স এর প্রিপারেশনে করতে পারেন, কিন্তু এই সিটি স্ক্যান, এমআরআই এগুলোর জন্য আসলে ওনাকে অনেক বেশি হার্ড ওয়ার্ক করতে হচ্ছে। কারণ এবং ওনাকে এইসব স্লাইড রেডি করে মোটামুটি অনেকদিন আমিও তাকে রেগুলার নক করতে হচ্ছে ইনবক্সে, স্যার সেশন কবে। যদিও আমি যদি স্যারকে বলি স্যার কালকে ডিমেনশিয়া একটা সেশন করেন, স্যার কালকে আই থিঙ্ক উনি কালকে এটা করতে পারবেন। কিন্তু এই চ্যালেঞ্জ গুলো নেওয়ার জন্য এবং কষ্ট করার জন্য স্যারকে আসলে ধন্যবাদ। আমরা নেক্সট মান্থ 3rd চ্যাপ্টার শেষ করব, তারপর আমরা স্যারের সঙ্গে কিছু ক্লিনিক্যাল আমাদের যেটা প্ল্যান আমরা করে ফেলছি অলরেডি, আমরা কেস প্রেজেন্টেশন, নিউরোলজি কেস প্রেজেন্টেশন স্যারের সাথে করব, সাথে আমাদের দেশের স্যাররাও থাকবেন এবং স্যারের ক্লিনিক্যাল প্রেজেন্টেশন গুলো শুরু করবেন। স্যারকে আরেকবার ধন্যবাদ জানিয়ে আমি আমাদের আজকে চেয়ারপারসন ডক্টর ফাতেমা দোজা ম্যাডামের কাছে যাচ্ছি এবং আমাদের আজকের বুক পার্টনার হেলথ কেয়ার ফার্মাসিউটিক্যালসকেও ধন্যবাদ।
থ্যাংক ইউ ভেরি মাচ ডক্টর এহসান। অ্যাকচুয়ালি এটা একটা খুবই বাংলাই বলছি, যেহেতু ডক্টর প্রবীণ এখন বাংলাদেশেই পশ্চিমবঙ্গে আছেন, মানে উনি বাংলাও বোঝেন, তো শেষটা বাংলাতেই করি। বিডি ফিজিশিয়ানের যে একাডেমিক উদ্যোগটাকে আমি ভীষণ পছন্দ করি এবং স্বাগত জানাই, যার মাধ্যমে যারা পোস্ট গ্রাজুয়েশনে আছে কিংবা মাত্র এমবিবিএস করে জেনারেল ফিজিশিয়ান হিসেবে আছে, তাদের জন্য এটা খুবই উপকারী। এবং এমনকি আমরা যারা পোস্ট গ্রাজুয়েশন করেও ফেলেছি তারাও হচ্ছে একটা রিভিশনের সুযোগ পাই। তো এই উদ্যোগটা সবার জন্যই খুবই উপযোগী এবং আমি তারপর ধন্যবাদ জানাতে চাই ডক্টর প্রবীণকে। প্রবীণ অনেক আগে থেকেই রেগুলারলি বিডি ফিজিশিয়ানের এই একাডেমিক যে উদ্যোগটি এটার সাথে জড়িত আছেন এবং খুব চমৎকারভাবে ক্লিনিক্যাল নিউরোলজি অ্যাজ ওয়েল অ্যাজ কিছু পোর্শনে ইমেজিংটাকেও এনেছেন। তো আজকের যে ডিমেনশিয়া, তারপর হচ্ছে যে বেসাল গ্যাংলিয়া এবং পার্কিনসনিজম এর উপরে যে আমাদের আলোচনাটা হলো, সেটা ক্লিনিক্যাল মোস্টলি এবং কিছু রেডিওলজিক প্যাটার্ন যেগুলো খুব প্রয়োজন। তো এর মধ্য দিয়ে যে বার্তাটা আমরা পেলাম সেটা হচ্ছে যে আসলে যুগপথ ক্লিনিক্যাল অ্যাজ ওয়েল অ্যাজ ইমেজিং দুটোর একটা যোগাযোগ দরকার। শুধুমাত্র হিস্ট্রি ছাড়া, একটা পেশেন্ট ছাড়া রেডিওলজিস্ট যখন একটা রিপোর্ট করেন তখন হচ্ছে তার সামনে পেশেন্টটা থাকেন না, তিনি মোটামুটি অন্ধ। তো তার সামনে যে কাগজটা থাকে সেটার মধ্যে শুধু অ্যাডভাইসটুকু অধিকাংশ ক্ষেত্রেই থাকে, যে এমআরআই ব্রেইন অথবা এমআরআই উইথ এপিলেপসি প্রোটোকল, এমআরআই এমআরভি উইথ কন্ট্রাস্ট এরকম। কিন্তু আমাকে কি দেখতে হবে, পেশেন্টটা আসলে কি নিয়ে এসছে, তার কি ধরনের, তার কি কোরিয়া আছে কিনা, তার এপিলেপসিটা কোন ধরনের এপিলেপসি, এবং কিছু ফাইন্ডিং সহ যদি একটা কাগজে সামান্য হলেও লিখে দেওয়া যায় যে তার সেলুলোপ্লাজমিন লেভেল এত, অথবা তাকে আমি প্রভিশনাল ডায়াগনোসিস ভাবছি যে আমরা একটা এপিলেপসি, অথবা আমরা ভাবছি লিম্ফোমা, অথবা হচ্ছে পার্কিনসনিজম, অথবা অ্যালঝাইমার্স ডিজিজ, অথবা হচ্ছে উইলসনস ডিজিজ, তাহলে অনেকখানি সুবিধা হয় যে হোয়াট টু সি। এবং তার চাইতে বড় কথা কি যে যখন স্ক্যান গুলো হয়, এটা খুব ইম্পর্টেন্ট আমার কাছে, যেটা মোস্ট ইম্পর্টেন্ট মনে হয়, যেটা রেডিওলজিস্ট কিন্তু নিজে বসে স্ক্যান করেন না। সো যখন স্ক্যান গুলো হয় তখন ক্লিনিশিয়ান যদি তখন স্ক্যানটা করে হচ্ছে রেডিওগ্রাফার বা সিটি টেকনোলজিস্ট অথবা এমআর টেকনোলজিস্ট। তো আপনারা যদি এটুকু বলে দেন যে উই নিড টু সি দ্য মিড ব্রেইন অথবা উই নিড টু সি দ্য থ্যালামাস, তাহলে হচ্ছে যে সে স্পেসিফিক্যালি মানে ওই জায়গাটার উপর জোর দেবে এবং তার মাথায় থাকবে, বা সে পরীক্ষাটা নিখুঁত ভাবে করবে এবং সেই প্রোটোকল অনুযায়ী করবে। আদারওয়াইজ কিন্তু এটা কোয়াইট হচ্ছে ইম্পসিবল। যেমন আজকে ইয়ে নিয়ে কথা বলার কথা ছিল, পিটুইটারি নিয়ে কথা বলার কথা ছিল। পিটুইটারিতে যেটা হয় যে অনেক সময় পিটুইটারি মাইক্রোঅ্যাডিনোমা, আমরা সাইন সিমটম গুলো বলি যে তার হরমোনাল ইমব্যালেন্স, তার অ্যামেনোরিয়া অথবা হচ্ছে তার কিছু রিমোট সাইন সিমটম অ্যাপিয়ার করে, কিন্তু আমরা বলে দেই না যে এমআরআই ব্রেইন টু সি দ্য পিটুইটারি মাইক্রোঅ্যাডিনোমা। এখন যখন এই পিটুইটারি মাইক্রোঅ্যাডিনোমা দেখবো, ওটা টোটালি একটা আলাদা প্রোটোকলে ডাইনামিক কন্ট্রাস্ট এনহ্যান্সড সিটি অথবা ডাইনামিক কন্ট্রাস্ট এমআরআই তে করতে হবে। সো ইট ইজ ভেরি ইম্পর্টেন্ট টু অ্যাডভাইস দ্য অ্যাকচুয়াল protocol and to mention your provisional diagnosis. তো আজকে অত্যন্ত চমৎকার একটা একাডেমিক প্রোগ্রাম হলো, খুব ভালো লেগেছে আমার। এবং সেই সাথে এই বার্তাটাও সবার কাছে পৌঁছে যাক যে ক্লিনিক্যাল যে ইনফরমেশন গুলো, এগুলো আসলে ডায়াগনোসিসের জন্য খুবই 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 জরুরি। আদারওয়াইজ আপনি যদি শুধু বেসাল গ্যাংলিয়া হাইপার ইন্টেন্সিটি বলেন, রেডিওলজিস্ট শুধু ওই বেসাল গ্যাংলিয়া হাইপার ইন্টেন্সিটি বলে এটাকে ইস্কিমিয়া বলিয়ে বলে দিবে, কিন্তু তার যে সেই পেশেন্টের আসলে ডিমেনশিয়া ছিল কিনা, সেই পেশেন্টের কোনো উইকনেস ছিল কিনা, তার অন্যান্য কোনো সাইন সিমটম ছিল কিনা, সেটা মানে কিছুতেই খেয়াল করবেন না। শুধু রেডিওলজিস্ট না, এটা আরো একটা বিষয়, সেটা হচ্ছে প্রেসক্রিপশনটা আসলে আমরা বলে দিই আমাদের রেডিওগ্রাফারদেরকে যে টু ফলো দ্য প্রেসক্রিপশন। প্রেসক্রিপশনে যদি এরকম থাকে যে এখন যেমন আমরা করি, সেটা হলো যে সিপি অ্যাঙ্গেল ইভালুয়েশন ইন কেস অফ রেডিয়াল নার্ভ প্যাথোলজি, হ্যাঁ, যে হয়তো ট্রাইজেমিনাল নিউরালজিয়া পেশেন্ট হচ্ছে কমপ্লেন করছে, তো রেডিওগ্রাফার যিনি বা সিটি টেকনোলজিস্ট যিনি, এমআর টেকনোলজিস্ট যিনি, তিনি যদি ওই জায়গাটুকু খেয়াল করেন যে টু সি দ্য ক্রেনিয়াল নার্ভস, তাহলে হচ্ছে খুবই চমৎকার ভাবে উনি ট্রাইজেমিনাল নার্ভের অ্যাবারেন্ট কোনো ভেসেল সেটাকে কম্প্রেস করছে কিনা, অথবা হচ্ছে যে একদম পেট্রাস বোনের ভিতরে যেখানে ফেসিয়াল নার্ভের ওই অংশটুকুতে কোনো অ্যাবারেন্ট আর্টারি আছে কিনা, অথবা হচ্ছে সিএসএফ কোনো পোর্শন আছে কিনা যেটা হচ্ছে ফেসিয়াল প্যারালাইসিস করে। তো এটা খুবই ইম্পর্টেন্ট। আপনি প্রেসক্রিপশনের একটা কোনায় যদি লিখে দেন যে ফেসিয়াল প্যারালাইসিস, অথবা হচ্ছে এটা ওর হচ্ছে মুখ বেঁকে গেছে বা এরকম, কারণ তাহলে রোগীটা একদম এক্সাক্ট ডায়াগনোসিসের কাছাকাছি পৌঁছায়, স্ক্যানটা ঠিক মতো হয়। এবং একটা স্ক্যান ঠিক মতো হলে তখন রেডিওলজিস্ট অ্যালং উইথ দ্য গুড স্ক্যান, অ্যালং উইথ দ্য গুড প্রোটোকল, অ্যালং উইথ দ্য হিস্ট্রি, দে ক্যান রিচ নিয়ার বাই ডায়াগনোসিস। তো সবাইকে অনেক ধন্যবাদ। বিডি ফিজিশিয়ানের যারা আজকের অনুষ্ঠানের আয়োজক, আজকের অনুষ্ঠানটি স্পন্সর করেছেন সম্ভবত হেলথ কেয়ার ফার্মাসিউটিক্যাল, তাদেরকেও অনেক ধন্যবাদ। অ্যান্ড অনেক ধন্যবাদ ফিজিশিয়ানদেরকে যারা কষ্ট করে আজকের অনুষ্ঠানটি দেখেছেন। এবং অবশ্যই ডক্টর প্রবীণ কুমার যাদব, আপনাকে অসংখ্য ধন্যবাদ। থ্যাংক ইউ ভেরি
ম্যাডাম,
মাচ।
একটু আবৃত্তি না শোনালে তো হবে না, একটু শুনিয়ে দেন, একটু আমরা 4 লাইন শুনিয়ে দেন, তারপর আমরা চলে যাই।
Yes, sir. আবৃত্তি শোনার জন্য খুব সম্ভব 43. I can see that there are only 43
এই জন্যই তো
people.
তাড়াতাড়ি শুনিয়ে ফেলেন।
আচ্ছা, খুব ওরকম কিছু
এটা আমরা
পারবো না
রেকর্ড করে
আসলে।
আবার আমাদের গ্রুপে দিয়ে দিব, চিন্তা করেন না, যাতে সবাই দেখতে পারে।
খুব সবার তো আসলে পছন্দ না, তাই না? মানে খুব
তাও একটু
আচ্ছা,
শুনি, সমস্যা নেই।
এনিওয়ে, হ্যাঁ, খুব অল্প করে। তো রিসেন্টলি শঙ্খ ঘোষ প্রয়াত হলেন। শঙ্খ ঘোষের যে বহুল প্রচলিত এবং বহুল পছন্দের যে কবিতাটা মুখ ঢেকে যায় বিজ্ঞাপনে, আজকের বাংলাদেশ, আজকের পৃথিবীর সাথে সবকিছুর সাথেই মিলে যায়। হ্যাঁ, আমরা নিজেদের জন্য জীবনকে যেভাবে সাজাই, যেভাবে যাপন করি, তারপরেও দেখা যায় যে তার চাইতে বেশি আশেপাশের জিনিস অরিজিনাল সত্যটাকে এবং ঢেকে দেয় অনেকখানি। তো শঙ্খ ঘোষের কবিতা, একলা হয়ে দাঁড়িয়ে আছি তোমার জন্য গলির কোণে, ভাবি আমার মুখ দেখাবো, মুখ ঢেকে যায় বিজ্ঞাপনে, একটা দুটো সহজ কথা বলবো ভাবি চোখের আড়ে, জৌলুসে তা ঝলসে ওঠে বিজ্ঞাপনে রং বাহারে। কে কাকে ঠিক কেমন দেখে বুঝতে পারা শক্ত খুবই। হারে আমার বাড়িয়ে বলা, হারে আমার জন্মভূমি। বিকিয়ে গেছে চোখের চাওয়া, তোমার সাথে ওতপ্রোত নিয়ন আলোয় পূর্ণ হলো যা কিছু আজ ব্যক্তিগত। মুখের কথা একলা হয়ে রইল পড়ে গলির কোণে, ক্লান্ত আমার মুখোশ শুধু ঝুলতে থাকে বিজ্ঞাপনে। ধন্যবাদ।